Hi guys, good afternoon. So let's start with the first question. A 32-year-old man reports that whenever he sees a red traffic light, he immediately understands that it is a divine message confirming that he is the king of an alien world who will soon rule over the earth, right? So what we are seeing is there's a perception, there's a normal perception, and to it a delusion of grandiosity is being attached. So in which clinical condition a delusion is attached to a normal perception? किसमें होता है ऐसा? It happens in delusional perception. It happens in delusional perception. So you remember that. So if we have a normal perception and to it a delusion is being attached, this is called as delusion of perception. Okay. How to differentiate it from delusion of reference? See, delusion of reference mein na, they would not give things like this. They will first of all, in delusional perception, the perception and the delusion is completely unrelated. It's called as ununderstandable. The perception and the delusion attached has no relation whatsoever. It is completely ununderstandable, right? In delusion of reference, had this been delusion of reference, probably it would have said that the moment he sees a light, he believes that it's a symbol that stop now, something of that sort, right? Which still makes sense. When it is completely different, ununderstandability, that is what is called, that is when we make the diagnosis of delusion of perception. Delusion of grandiosity क्यों नहीं है? Because there is a perception involved. Here a perception is also involved. We have a perception, we have a delusion, they are not linked to each other at all. That is what makes it delusional perception. Yeah, there is grandiosity also here, but the component of perception has been given in the question. That is why you have to make a delusional perception. Is it clear now? Is it clear now? Prakhar is saying, sir, there's a glitch in the app. When I started the test, timer countdown started from 44 minutes, got only 44 minutes to solve all the question. Prakhar, it's not a glitch. The window of the test was to get over at 2 p.m. So you must have started late. If you start later, then you will see only that duration. Those of you who can't see the screen, please refresh. You have to start the test well before the window is over. So if you started 1:13, तो 45 minutes मिलेंगे. चलिए. Which of the following statements about negative symptoms of schizophrenia are true? They respond well to typical antipsychotics? No, they do not respond well to typical antipsychotics or even atypical antipsychotics. Remember, negative symptoms do not respond well to medications. They are caused by decreased dopamine in mesocortical tract. This is correct. We talked about mesocortical tract. They include avolition and alogia. This is correct. Avolition, apathy, anhedonia, affective flattening, alogia. So all these are negative symptoms. Avolition, apathy, anhedonia, affective flattening, asociality. All of them are negative symptoms. So this statement is correct. They are good prognostic factors? No. Negative symptoms are bad prognostic factors. Okay? So statement 2 and 3 are correct. So our answer becomes 2 and 3. No, you would not get this PDF. This would be uploaded in the app only. और पीडीएफ तो भी बनी भी नहीं है. लेट मी मेक इट फर्स्ट. पहले कैसे कर दूं? अ 35-year-old man on haloperidol develops sudden neck twisting and jaw locking. So neck is twisted, jaw is locked, and it is sudden. This occurred 2 days after starting the medications. So what is the diagnosis? It is going towards acute dystonia. Acute dystonia. And we know that the drug of choice for acute dystonia is parenteral anticholinergics. Parenteral anticholinergics. Parenteral anticholinergics. So Let's look at it. Trihexyphenidyl is an anticholinergic drug, but not orally. We have gotten promethazine, which has got anticholinergic property and can be given intramuscular. ठीक है? Propranolol would be the drug of choice for akathisia. हाँ, second option is trihexyphenidyl, but it is oral. We want to give it parenterally. We want to give it parenterally. Orally, it will take time now. A 42-year-old patient on long term. So the moment you see long term antipsychotics, what is it suggesting? This is a buzzword for what? The moment you see long term antipsychotic, you are thinking about TD. But let's look at it. The complete statement develops involuntary chewing movement and lip smacking. So this is classical TD symptom. Which of the following is true about this condition? It always resolves when antipsychotics are stopped. Unfortunately, no. In many conditions, tardive dyskinesia is a progressive condition. Even if you stop the medications, even if you give treatment for it, it doesn't stop, it keeps on worsening. It is caused by D2 receptor downregulation? No. We talked about it. It is caused by the hypersensitivity of receptors. Treatment includes switching to olanzapine. Actually, one of the treatment is switching to one of the atypical antipsychotics, and olanzapine is one of the drug with very low chance of TD. It is more common with atypical? No, more common with typical. So C becomes the best answer here. One of the treatment can be to switch to the olanzapine. Which antipsychotic is least likely to cause tardive dyskinesia? Shalini is asking, sir, can't we see our responses now in the app? Shalini, you can. You can. I think you have to quit the test and then go back. Dikh jayega. Yeah. So which antipsychotic is least likely to cause tardive dyskinesia? Answer is the antipsychotic which has minimum EPS, which is clozapine. Valbenazine is the treatment of tardive dyskinesia. I'm asking which antipsychotic is least likely to cause tardive dyskinesia, that is clozapine. So because olanzapine has very low chance of causing TD, it can be used. Okay? A 30-year-old man with TRS is started on clozapine. Which monitoring is mandatory? We know that. We do ANC and TLC monitoring. We know that if the patient is on clozapine, we do ANC and TLC monitoring once a week for first 6 months, once in 2 weeks for next 6 months, and once in 4 weeks till clozapine is continued. Till clozapine is continued. याद रहेगा? Once a week, 6 महीने, once in 2 weeks, next 6 months, once a month. After that, LFT daily, weekly not required. CBC actually not required, but CBC would include TLC and DLC. So that becomes the better answer. ECG no, RFT no. I hope all of you got it right. And this is done because of the possibility of agranulocytosis. ठीक है. Match the following antipsychotic with their notable characteristics. So penfluridol is an antipsychotic with almost a T-half of 7 days. Very long T-half. Penfluridol is an antipsychotic with the T-half of 7 days. Ram is asking about the myocarditis. Ram, for myocarditis, first of all, we don't usually routinely do ECG. And if it is done before starting the clozapine. Once it has been started, you don't have to do it weekly. Okay? So penfluridol has a T-half of around 7 days. Okay? It is one of the antipsychotics with longest half-life. Ziprasidone, we know, we talked about this, QTC prolongation. Aripiprazole is known for its partial D2 agonism. And thioridazine can cause irreversible retinal pigmentation. So A goes with 2, B1, C3 है, C4 है, C4. So C4, we answer it as C. C. हाँ ठीक है, ठीक है. मैंने एक चीज ठीक नहीं बोली है, प्लीज करेक्ट इट. पेनफेरेडॉल कैन बी यूज्ड once a week. हाफ लाइफ इज नॉट 7 days, हाफ लाइफ इज लेसर. लेकिन देख रहा हूं मैं कितनी हाफ लाइफ है, शायद 60 hours कुछ है, बट दिस इज प्लीज करेक्टेड. इट कैन बी यूज्ड once a week. हाफ लाइफ नहीं है, बोथ आर डिफरेंट थिंग्स ऑफ कोर्स. प्लीज करेक्टेड, गलती करके मत आना और फिर मुझे गाली मत देना. इसी डर से मैंने चेक कर लिया है. नहीं, इट इज नॉट स्टक, आई वॉज चेकिंग, आई मेड दैट मिस्टेक. इट इज यूज्ड once a week. इट्स हाफ लाइफ इज लेसर. हाँ ठीक है. A 25-year-old woman presents with persistent sadness, anhedonia, weight loss, early morning awakening and feeling worse in the morning. मानव कह रहा है डन सर. भाई तुम लोग आपस में चैट कर लो यार. देयर इज समथिंग कॉल्ड एज व्हाट्सएप. ये पब्लिकली हमारे सामने क्यों डिस्कशन कर रहे हो तुम लोग? हाँ, कितने सारे लड़के, उनका वैसे ही मन नहीं लग रहा पढ़ाई में, वो और जेलस फील कर रहे हैं. 25-year-old woman presents with persistent sadness, anhedonia, weight loss, early morning awakening, and feeling worse in the morning for 4 weeks. Which specifier best describes her depression? So remember, we talked about atypical depression. We talked about melancholic depression. In atypical depression, we said that the biological features are reversed. Normally in depression, sleep is less, appetite is less, weight is lost. But here the sleep is more, appetite is more, weight is gained, and we said that the depression is reactive, mood is reactive. If something good happens, the person gets happy. This was atypical depression, lead-in paralysis. And in melancholic depression, we said that it is the worst form because first of all, patient feels misery. The feeling is of misery. Mood does not react to anything. There is anhedonia. Mood does not react to anything. There is anhedonia. Depression is worse in the morning. There are significant sleep appetite disturbances, significant biological symptoms. Remember all of that? So melancholic depression is kind of severe form. Reactive atypical depression is comparatively milder. So यहाँ पे we are having persistent sadness, anhedonia, lot of weight loss, early morning awakening, feeling worse in the morning. So all of this goes towards melancholic feature. Melancholic feature. ठीक है. Classical question. Which of the following statements about suicide factors are true? A previous suicide attempt is the most important risk factor. Of course, we talked about it. The single most important risk factor for future suicide attempt is a past suicide attempt. The female gender is at higher risk than males? No. What did we say? Males attempt suicide more, whereas, sorry, females attempt suicide more, whereas males complete suicide more. We said females attempt suicide more, but males complete suicide more. Remember, females attempts are usually of lesser lethality. So despite attempting it less, males have a higher chance of completing suicide. So this statement is not correct. Hopelessness is a risk factor. We talked about it. Yes, hopelessness is one of the risk factors. And substance abuse increases the risk. Correct. So 1, 3 and 4 are correct. 2 is not correct. So attempting is not the risk. Risk factor is something that takes it towards completion. Female attempt more, but males complete more. So males are at a higher risk of suicide than females. ठीक है. अटेम्प्ट करने से फर्क नहीं पड़ता ना, चीज कंप्लीट होनी चाहिए, यू नो. A 28-year-old patient presents with elevated mood, decreased need for sleep, feel rested after 3 hours, grandiosity and excessive spending for 10 days with significant functional impairment. What is the diagnosis? So we have been given history of only one episode of mania. How will we differentiate mania from hypomania? Remember, we said that the symptoms of mania and hypomania are same, but the impairment is lesser in hypomania. and the severity is lesser in hypomania. Now look at the question. They are given significant functional impairment. They are giving this line to help you differentiate between mania and hypomania, because otherwise symptoms are same. So we are saying we have been given history of one episode of mania. Now we know that even a single manic episode is enough to make a diagnosis of bipolar 1. So the answer becomes bipolar 1. For bipolar 2, we need to have at least one episode of depression plus one episode of hypomania. It cannot be substance induced because there is no history of substance. And cyclothymia is symptoms of hypomania and depression. Hypomania and depression continuing for more than 2 years. Symptoms of hypomania and depression, but not enough to make the diagnosis of episode. Now, depressive symptoms are there, but they are not so much that you can make a diagnosis of depressive episode. So symptoms of hypomania and depression, not enough to make a diagnosis of episode. For more than 2 years. Okay? Which mood stabilizer is the worst that you should never give? If you are given only this much, your answer should be Valproate. It is in the options. Valproate is the worst. Valproate, worst. Antipsychotics, best. Lithium, in the middle. Yaad rahega? This is something that is asked multiple times. Well, remember this. We should not forget this. Every second year, a question is coming from this table. A 35-year-old man on lithium therapy presents with polyuria, polydipsia, serum sodium is increased. What is happening? We know that it can be because of lithium-induced diabetes insipidus. Lithium interferes with action of ADH, anti-diuretic hormone. Anti-diuretic hormone. Somebody is asking why not lithium toxicity? Beta, because lithium toxicity would present with what? It presents with abdominal symptoms like abdominal pain, nausea, vomiting, and CNS symptoms like coarse tremors, like ataxia, like dysarthria. So we have to look at the symptoms now. There are no symptoms. There are no symptoms given here. That is why it is not lithium toxicity. Akhil is saying, sir, can you extend today's midday module time? Not needed, na? Even after the time, if you appear for midday module, you will get the rank and everything. Everything will happen. Okay? Clear hai ye? Is it clear now? A 30-year-old woman experiences sudden episode of intense fear with palpitation, sweating, and feeling of impending doom, lasting 10 minutes. Between the episodes, she constantly worries about the next attack. Simple question. We have been given history of panic attacks and we have been given history of anticipatory. This line is anticipatory anxiety. We have been given history of panic attacks and we have been given history of anticipatory anxiety. It goes towards panic disorder. Shubhra is asking, sir, what is impending doom? So, beta, impending doom is that the end is near. The end is near. Doom matlab doomsday, end. So, feeling of impending doom means the end is near. And Shubhra, did you not attend the class? ये तो हमने discuss किया था, है ना? See, in psychiatry na, please ensure that you are, for those of you who are just attending the END, please ensure that you do one class at least once. In psychiatry, even if you do it once, majority of the concepts will stay with you. Psychiatry is that kind of subject. Not doing it even once is not good. And also remember, for shorter subjects, sometimes students make the mistake, they think the shorter subjects can be done just by doing PYQs or just by doing BTR. Don't do that. Shorter subjects are the lowest hanging fruits, one of the lowest hanging fruits. It's very easy to get all the questions correct in the shorter subjects, right? And they are of very small duration, 5 hours, 6 hours, 7 hours. So why are you not getting at least all the questions correct from shorter subject? For some bigger subjects, if we don't have time, I can still understand. Don't make the mistake of not doing shorter subjects properly. You will definitely get those 35 questions correct in the exam. ठीक है? चलो. Gokul is saying, sir, can I do late night PYQ in morning? No, Gokul. I will come to your home and I will stop you. मैं तुम्हारा हाथ पकड़ लूंगा कि सुबह कैसे कर रहा है. जब लेट नाइट लिखा है तो लेट नाइट में ही कर. Of course you can do it, my dear. But you should not idly discipline तब आएगा when you do it then and there. But नहीं तो नहीं. मैं थोड़ा जोक्स करता हूँ, राइट? प्लीज नो डू नॉट गेट ऑफेंडेड, है ना? चलो. गोकुल इज सेइंग आई फील सो स्लीपी. हाँ तो ठीक है, दैट्स अ गुड रीजन टू डू इट इन द मॉर्निंग. चलेगा गोकुल. हाँ, यू कैन डू इट इन द मॉर्निंग यार. ऑलराइट. समबडी सेइंग सर व्हाई नॉट जीएडी. बताओ भाई, व्हाई नॉट जीएडी? डॉक्टर कावेरी इज आस्किंग व्हाई नॉट जीएडी. कौन बताएगा व्हाई इज इट नॉट जीएडी? In GAD, what is the buzzword that we studied about? Excessive worries in all the domains. And the anxiety is always there. There are no episodes. The person will always be anxious. Very good. Very good, boys and girls. Very good. We don't care about the 6 month duration so much. We care more about the symptoms. Do not make the mistake of making diagnosis on the basis of duration. We will make the diagnosis on the basis of symptoms. Very good. All of you, very good. ठीक है बेटा. डॉक्टर कावेरी, यू अंडरस्टूड आई होप. सो पैनिक डिसऑर्डर. A 25-year-old teacher avoids staff meetings due to fear of being judged or embarrassed. This is affecting her work performance. What is our diagnosis? We are thinking of social phobia. What is the treatment for pharmacological treatment for phobias? We say we give short-term benzos. And we give long-term SSRIs. And we also do therapy in the form of behavioral therapy or cognitive behavioral therapy. So propranolol as needed can be used, but not first line. Sertraline is a SSRI. That definitely can be used. Alprazolam as needed will not solve the problem for you. If you take it for for few days, on those days anxiety will be taken care of, but it does not resolve the issue for you. So it is not a good choice. Buspirone is also a drug which can be used in anxiety, but it is not as effective as benzodiazepines. Although it has a benefit that it is not habit forming. It works on serotonin receptors, 5-HT1A receptors, but it is not as effective, so it does not count as a first line. So out of the 4 options, the only first line is sertraline. So I think some of you would have gotten confused between B and C, and that's a fair confusion because benzodiazepines are also first line, but as needed would not solve the problem for you. But if you made a mistake of writing alprazolam as needed, that's an understandable mistake. ठीक है? Propranolol को हमने, remember the first line treatment, we did not talk about propranolol. It can be used as and when needed, but not the first line treatment. है ना? If alprazolam daily was option, even then we would not take it. Why? If you take alprazolam daily, it would be making you dependent on alprazolam. Kaise? How will she do it on a SOS basis? She is a teacher. She has to go to office every day. She has to do meetings frequently. And if she start taking alprazolam on all the days of meetings, she will soon become dependent on it. So that is why we prefer SSRIs. Which of the following statement about agoraphobia are true? It involves fear of open spaces. Yes. One of the fear could be fear of open spaces. It is often comorbid with panic disorder. Correct. We said that the commonest comorbidity is panic disorder. It can lead to patients becoming housebound. Yes. We said that because patient is afraid of going out alone and is afraid of using public transports. Sometimes patients end up being confined to their houses. It only involves fear of crowded places. No. While fear of crowded places is there, if we say it only involves, then that is claustrophobia. If we say it only involves of crowded places, that is incorrect. Had they not given this statement only, then all of them would have been true. So that only word was the trap. That was a trap. Puja ho gaya na? That was the trap. Very good. गोविंद सर ने हमारी टर्मिनोलॉजी चेंज कर दी. Rather than saying silly mistakes हो गया, पूजा हो गया. See, that's the power of GRG sir. He can single-handedly change the terminology. Chalo. But I'm sure no girl with the name Pooja likes GRG sir now. A 27-year-old man spends 4 hours daily checking locks and washing hands. He recognizes this as excessive but feels anxious if he does not perform these behaviors. Diagnosis is as simple as it gets: OCD. What is the first line treatment of OCD? We can use SSRIs or clomipramine, or we can do ERP, which is a kind of CBT, exposure or response prevention, which is a kind of cognitive behavioral therapy. Here we have been given options of medication. So A and B are both first line, but we have to pick. We will pick SSRIs because they have a better side effect profile than clomipramine. Because of a better side effect profile than clomipramine, fluoxetine are preferred over clomipramine. ठीक है? ठीक है बेटा? Because of the better side effect profile, we are choosing fluoxetine over clomipramine. Which of the following OCD subtypes has the poorest response to ERP? This is actually a NEET PG PYQ. एग्जाम में आया था. आंसर है होल्डिंग डिसऑर्डर. जस्ट मेमोराइज इट. रट्टा मार लो. इट्स अ PYQ. Some of you must have already seen this question. It's a PYQ. A 30-year-old woman repeatedly pulls her hair, resulting in noticeable hair loss. She experiences tension before hair pulling and relief afterwards. A very simple question: trichotillomania. Trichotillomania. In excoriation, there is skin picking. Picking on the skin. This was a very simple question. I hope 100% of you got it right. Ritika is saying confused between A and C. Ritika beta, not acceptable. In this question, see, these questions you cannot afford mistakes. Ritika, तुमने क्लास नहीं की थी बेटा, I'm sure. Ritika, did you do the class? Did you take the class? फिर कैसे गलत कर दिया? NOS is not otherwise specified. कुछ मिस्टेक्स नहीं करनी है हमें, बेसिक मिस्टेक्स वी शुड नॉट डू. कोई बात नहीं, चलो ठीक है. As we continue revising, things will become better. Sometimes everyone does some silly mistakes. Dr. Krishna is saying, sir, please add the percentage in front of options, sir. Percentage. How many of you got it correct? That is there in the app, beta. Algorithm takes some time now. All the students have to submit their answer, then it calculates, but then it shows. It shows. दिखता है. A 24-year-old woman survives a car accident. 3 months later, she has nightmares, flashbacks, avoids driving, and is hypervigilant. Very simple question. History of a stressor followed by re-experiencing of the symptoms, avoidance, and exaggerated and arousal symptoms like hypervigilance. So all of this goes towards, and duration is more than 1 month. This is PTSD. ठीक है. Palak is saying, sir, but उसमें 6 months का timeline होता है. No, Palak. The 6 month is if the symptoms start after 6 months, then we call it PTSD with delayed onset. Then we call it PTSD with delayed onset. That's a different thing. Ankur is saying, sir, some patients after trauma develop PTSD and some do not. Why is it, sir? In fact, Ankur, most of the people after trauma do not develop PTSD, right? So trauma is one of the reasons, but it would not induce the illness in everybody. Na? It's like physical. I mean, it's like any other disorder. Even say 100 people got exposed to mycobacterium, the bacteria, but not everybody develops tuberculosis. Some will do, some will not. Hundreds of other factors are involved: immunity, amount of exposure, duration of exposure, multiple things are involved. Na? A 19-year-old student develops anxiety and difficulty sleeping 2 weeks after failing an important exam. So we have history of a stressor. Now, she is developing anxiety and insomnia. See, this is how they give the questions on adjustment disorder. They will give some stressor and they will give either some anxiety symptoms or depressive symptoms, but those symptoms are not severe enough to make another diagnosis. You can rule out major depressive disorder, no history of sadness given, no history of anhedonia given, no history of loss of interest given, and you can rule out GAD because the only symptom given is anxiety and insomnia for 2 weeks. They have not given excessive worries. They have not given physical symptoms of anxiety. Why is it not acute stress disorder? Because had it been acute stress disorder, we would be given history of re-experiencing of trauma. We would have been given history of avoidance. We would have been given symptoms of exaggerated arousal like hypervigilance. So because we have not been given those symptoms, it is not acute stress disorder. Also, we remember that PTSD and acute stress disorder are caused by severe traumatic events like accidents, like war, like earthquake. Whereas things that happen in routine life, like failing in the exam or losing a job, all these things are followed by adjustment disorder. So here the answer is adjustment disorder. Adarsh is saying, what is the difference? Difference between what? Adarsh? Ninja is saying, how to differentiate acute stress disorder and PTSD? Batao bhai, how will we differentiate between acute stress disorder and PTSD? Yes, on the basis of duration of symptom. PTSD continues for at least 1 month. Acute stress disorder between 3 days and 1 month. Okay. A 32-year-old woman presents with fatigue, headache, and abdominal pain for 2 years. A medical workup is normal. She spends daily hours worrying about these symptoms and visits doctor. So what have we studied? Preoccupation with the symptoms, preoccupation with the diagnosis. This is preoccupation with the illness or diagnosis. This is preoccupation with the symptoms. In conversion disorder, we will have neurological symptoms. And in factitious disorder, we will have faking of symptoms for medical attention. Faking of symptoms for medical attention. So here we have all the physical symptoms, preoccupation with symptoms. So it becomes somatic symptom disorder. Okay. Amisha is saying, why not D? Because we have not been given any history that she is faking the symptoms. A 28-year-old nurse frequently presents to emergency department with various symptoms. She has multiple surgery scars and extensive medical knowledge. And she seems to enjoy the attention from medical staff. Now, this is going very clearly in the diagnosis of, in the direction of factitious disorder. A medical personnel who is having medical knowledge, scars from previous interventions, and looks to be doing it for attention of medical staff. It is factitious disorder. So in factitious disorder, we have faking of symptoms for medical attention. In malingering, there is faking of symptoms for external incentives like avoiding jail or insurance money or avoiding duty. So for these things, when you fake symptoms, external events, external incentives, then it is malingering. If you are doing it for medical attention, it is factitious disorder. A 26-year-old woman is found wandering in another city with no memory of how she got there. She cannot recall her identity, but appears alert and oriented, and neuroexamination is normal. This is all going towards dissociative fugue. So, wandering in another city and cannot recall her identity. We know that this happens in dissociative fugue. And we also studied yesterday or day before yesterday that dissociative fugue is now considered a specifier of dissociative amnesia. Dissociative amnesia. Why is it not dissociative identity disorder? It would be characterized by a presence of multiple identities. यहाँ पे we are just being told that she does not recall her identity. And in dissociative identity disorder, there would be no history of wandering. No history of wandering. So it goes more in favor of dissociative fugue. Inzamul is asking what is specifier. Specifier means that some specific characteristic. There is a specific characteristic which can be added to the diagnosis. So dissociative amnesia, but it also involves dissociative amnesia means not being able to recall a part of memory. And if it is also involving travel, then we say dissociative amnesia with fugue. Okay? A 45-year-old man with chronic alcohol use presents with confusion, ataxia, and ophthalmoplegia. What is the treatment? All of us know that this is global confusion, ophthalmoplegia, and ataxia. And it is a part of Wernicke's encephalopathy. And for Wernicke's encephalopathy, you have to give parenteral thiamine. Naloxone would be given in patients who have taken opioid overdosage. Flumazenil is given for benzodiazepine. For benzodiazepine overdosage. So naloxone for opioid overdosage, flumazenil for benzodiazepine overdosage. Chalo ji. A 30-year-old man presents 12 hours after the last drink with tremor, sweating, anxiety, and mild hallucinations without altered consciousness. What is the most appropriate treatment? So in alcohol withdrawal, whether the person is presenting with simple withdrawal symptoms like tremors or say mydriasis, sweating, or whether he presents with hallucinations, or whether he presents with seizures, or whether he presents with delirium tremens, no matter what the presentation is in alcohol withdrawal, benzodiazepines are the drugs of choice. If it is alcohol withdrawal, no matter what kind of alcohol withdrawal, you will always give benzodiazepines as a drug of choice. You may add thiamine to prevent Wernicke's course of cough, but you would always give benzodiazepines. Isme haloperidol was a distractor. By giving hallucinations, we just wanted to distract you. Did anybody mark haloperidol? Koi fasa? Did anybody fall for it? Yes, good. So it was just a distractor to remind you that in alcohol withdrawal, no matter what symptom is given, always answer benzodiazepine. Harshit ne kaha, I missed the test. Harshit, thank you for informing us publicly. Harshit ne kaha ki everybody is talking about the questions and the options. Let me do something new. कुछ नया करते हैं. I missed the test. हर्षित अभी दे देना. Khushi saying, sir, it's my birthday today. Happy birthday, Khushi. Dr. Garima, sir, can we make it a little fast, please? No, Garima. We will all celebrate Khushi's birthday now. Happy birthday, Khushi. We don't care about Garima. Happy birthday, Khushi. Garima, sorry. तुम्हारा birthday आएगा तुम्हारे लिए भी गाना गाएंगे. Which of the following substance is most likely to cause tactile hallucinations? So we talked about it. It is cocaine. Cocaine can cause tactile hallucinations. Cocaine bugs और मैग्नन फिनोमिना. मैग्नन फिनोमिना. ठीक है, चलो. A 55-year-old man presents with pinpoint pupil, shallow breathing and decreased consciousness. So देखो pinpoint pupil, we have miosis, we have shallow breathing, which means we are having respiratory depression. So which substance abuse in overdosage can cause meiosis and respiratory depression? Of course, opioids. And if the person is having shallow breathing, you want to immediately reverse the overdosage. How will you do it? By giving naloxone. So we should remember this is for benzodiazepine overdosage. And naltrexone is primarily used for alcohol relapse prevention. Can also be used for opioid relapse prevention, but has no role in the toxicity. Yes, relapse prevention is same as maintenance treatment. A 68-year-old man develops acute confusion. See, the moment you see confusion, confusion means disturbance of consciousness. In the examination, they will use the word confusion. And then there are hallucinations. And there is fluctuating attention. Attention levels are also fluctuating after surgery. After surgery, if somebody is developing confusion, hallucinations, it goes towards delirium. It goes towards delirium. So how will you manage it? High dose benzodiazepine? Not so much. Had it been a delirium tremens because of alcohol withdrawal, we could have considered it, but not here. Address the underlying cause. This is always the main treatment of delirium. And if the patient is having too many hallucinations, you can add low dose haloperidol. Start haloperidol immediately. Not the best answer because we have been given the option of address underlying causes. Immediate CT scan is actually not a bad option. Immediate CT scan is actually not a bad option, but since they have given you history of delirium and since they have given you the exact treatment that is done, immediately identify underlying cause. That becomes the better answer. Why? The addressing of underlying cause may involve neuroimaging and it may involve other things also, like say oxygen saturation. Say after the surgery, the patient had developed fat emboli and that is leading to embolism. That will not come necessarily in CT scan. You'll have to look for all the causes. So that is why it becomes the better answer. Buzzword for delirium would always be confusional state. Confusional state. Confusional state. Okay? So underlying cause could be any. Hyponatremia, hypoxia, thousands of things that can cause it. So this is a better option. So CT scan, see, had it not been psychiatry class or medicine class hoti, so CT scan would have been marked by more of you. But again, if you look at the options clearly, when it says address underlying causes, now when you are looking at it, you realize that line covers things apart from CT scan also. Sachin thought B was a trap and marked C. कोई बात नहीं. A 24-year-old woman repeatedly steals small items from stores that she does not need and could easily afford. She experiences tension before stealing and relief afterward. She feels guilty, right? Every single symptom that we discuss in kleptomania is here. The person is stealing something which is of minimal value and she can afford easily. There is feeling of tension. After stealing, there is feeling of relief and then later guilt. This is classical history of impulse control disorder, kleptomania. Stuti is saying, sir, stealing a differential diagnosis. Stealing, differential diagnosis. First, lack of money. Second, wants nice things, can't afford it. Third, can't afford it. Fourth, antisocial. Fifth, for medical student, kleptomania. ठीक है स्तुति, very important table. चलो, a 35-year-old man is described as suspicious, holds grudges and perceives hostility in neutral comment, right? So he's suspicious, holds grudges. Remember we talked about it. If you take their pen, they do not forget it. In a diary they write it. This guy took my pen at 11:55 a.m. on 3rd of January. So do not forget, do not forgive. And even if you make a neutral comment, he feels that this is against me. So this all goes towards paranoid PD. So paranoid PD is suspicious. Schizoid PD is loner, stays alone. Schizotypal is odd and eccentric. Avoidant personality, scared that others will judge me. ठीक है, ठीक है. A 28-year-old woman has unstable relationships, a fear of abandonment, recurrent suicidal gestures, and identity disturbances. So, with that, you make the diagnosis of borderline personality disorder. What is the most effective psychotherapy? We know that DBT, dialectical behavioral therapy, is used for borderline personality disorder. In DBT, what primarily you use, what primarily you do, you teach the patient not to see things in black and white. We talked about this. One of the defense mechanism used in borderline PD is splitting. Splitting is seeing things in black and white. Either a person is extremely good or a person is extremely bad. If you start looking the world in black and white, you would be in a lot of trouble because nobody is all good and nobody is all bad. So in DBT, this is the primary thing that is done. You help person start seeing world not in black and white. A 19-year-old woman with a BMI of only 15 kilogram per meter square. We remember that for anorexia, the BMI should be less than 18.5 kilogram per meter square. She restricts food intake, has fear of weight gain, and sees herself as overweight despite being underweight. What is this called as? We talked about this line. Which disturbance? This is which disturbance? This is which disturbance? Yes, Aditya, very good. This is body image disturbance. Body image disturbance. So we have all the symptoms: low BMI, body image disturbance, restricts food intake, fear of weight gain. It all goes towards anorexia nervosa. In bulimia, weight is usually normal. What is ARFID? It is, बताओ ARFID क्या होता है? So you must have seen some children who do not eat food. They are very picky. They are very restrictive. So a lot of kids do not eat food because they don't like the sensory characteristics of the food, like the smell or taste. They don't like the smell or taste of the food, because of which they restrict the food intake. But in that, the history would be they're very picky eaters, but there are certain things that they eat a lot, right? So that is avoidant restrictive food intake disorder. A 22-year-old woman with bulimia nervosa presents with muscle weakness and palpitation. ECG show classical flattened T wave and U wave. This is all in going in favor of hypokalemia. ठीक है? In bulimia, because of episodes of purging, episodes of vomiting, the patient can develop hypokalemic and hypochloremic alkalosis. So what you are seeing here is all hypokalemia, hypokalemic and hypochloremic alkalosis. A 21-year-old student reports irresistible episodes of falling asleep during lectures. Not so uncommon. So this is the history of sleep attack. Often with sudden loss of muscle tone triggered by laughter. What can be the diagnosis? So we know that narcolepsy, but they are asking about type 1 and type 2. So narcolepsy type 1 is with cataplexy. Narcolepsy type 2 is without cataplexy. So it becomes narcolepsy type 1. Type 1. ठीक है? A 16-year-old boy shows defiance towards parents and teachers, arguments and annoys, but not violated any major rule. So we yesterday talked about it, that in oppositional defiant disorder, there would be a history of defiance, disobey the seniors and the parents, and annoys. But when it comes to conduct disorder, we will have things like stealing, bullying, lying, running away, all these serious things. In intermittent explosive disorder, there are episodes of aggression on trivial matters. Okay, so out of these, our ODD becomes the most important. It becomes the diagnosis which matches the description of the question. ठीक है, क्या लिखा है सर, अगर नेवर ना होता तो कंडक्ट नहीं. इवन देन सी लुक एट द सिम्टम्स ना. If the symptoms are only defiance and arguments, even if they had not given this line, even then we would have made the diagnosis of ODD only. For us to make a diagnosis of conduct disorder, they have to give us history of lying, running away, cruelty, bullying, all those things. है ना? A 32-year-old man has normal erections during masturbation and sleep, but has difficulty maintaining an erection during intercourse. What is the most likely cause? So we talked about it yesterday, that if there are erections during sleep but not erection during intercourse, it means it's all anxiety. So it goes in the favor of psychogenic erectile dysfunction. अरे हमारे बच्चे बड़े हो गए. Nobody is making laughter emoji. That's so nice to see. The kids have grown up. Good, good, good. Proud of you guys. Very good. Nice. Very good. Now you guys are behaving maturely. I like it. Rachana is saying, what is DMD? Disruptive mood dysregulation disorder. It's a childhood disorder, childhood mood disorder, where the child has a lot of emotional outbursts, anger outbursts. It's always irritable. Things like that. All right. A 27-year-old man has intense sexual urges to observe unsuspecting people undressing, and they cause significant distress. So this is peeping Tom. This is voyeurism. Exhibitionism is arousal by exposing self. Voyeurism is arousal by watching others. Frotteurism is arousal by rubbing genitals against strangers. And sadism is arousal by giving pain. ठीक है, आते हैं क्वेश्चंस. पैराफिलियाज आर ऑफन आस्क्ड इन द एग्जाम्स. Shivangi is saying, does watching porn come under voyeurism? No. A 7-year-old boy has difficulty paying attention, is easily distracted. Difficulty paying attention, is easily distracted, fidgets constantly. This is hyperactivity. ठीक है. Difficulty paying attention, this is inattention. And interrupts others. Symptoms have been present at school and home for 8 months. What is the first line treatment? So if the question was still here, the answer would have been methylphenidate. But the parents are refusing stimulants. So if you are not allowed to give stimulant, then you have to give atomoxetine. Atomoxetine. How many of you did not read the last 4 words? How many did not read the last 4 words? पूजा हो गया? बस ठीक है. Answer is atomoxetine. Parents are refusing to give stimulants. Why are the parents refusing to give stimulants? Because see what happens is now when you give methylphenidate, the growth may slow down. There are some studies which say that temporarily the growth may slow down, although finally it catches up. So that is why a lot of parents are afraid. And when you give stimulant, that is why you say that give drug holiday. Give stimulant for 5 days, but for 2 days don't give stimulant. Why not clonidine? Because atomoxetine is considered better than clonidine. It has got better evidence. Because atomoxetine has got better evidence than clonidine. ठीक है बच्चे. A 10-year-old boy has multiple motor tics and vocal tics. What is the diagnosis? Tourette's disorder. नाम में ही देख लो. Persistent motor tic में only motor tic. Persistent vocal tic में only vocal tic. Provisional tic में अभी duration criteria is not met. So this is Tourette's disorder. And what is the drug of choice? We talked about it yesterday. Here the drug of choice is clonidine and guanfacine. Provisional tic disorder में duration criteria for tic disorder has not been met. Sometimes tic are there for very short duration, na? Then we call it provisional. A 5-year-old girl refuses to speak at school but talks normally at home. In one setting she is talking normally, in other she is not talking. This is the classical presentation of selective mutism, where the child is mute in one situation but is normal in the other situation. I hope all of you got it right. In expressive language disorder, there is disorder of expression of language, but it would be seen in all the settings. If it is being seen in only one setting, it becomes selective mutism. Why not social anxiety? Because we are being given a specific symptom of mutism here. Right? There is no other symptom of anxiety given here. So let's not presume it to be social anxiety. And then only in school it is being given. Which of the following statement about transference and counter-transference are true? We remember transference feeling patient develops for doctor, counter-transference feeling doctor develops for patient. So transfer is the feeling the patient develops towards therapist, correct? Counter-transference, therapy towards patient, correct? Both operate at unconscious level, correct? They should be ignored in therapy, no. We talked about it yesterday. Transference and counter-transference are actually used to interpret what is going on with the patient. So you cannot ignore it. We use it. So 1, 2, 3. According to the psychoanalytic theory, which defense mechanism involves attributing one's own impulses on another? We talked about it yesterday. Projection. A husband who wants to cheat on wife starts saying that actually wife is cheating on me. This is projection. What was reaction formation? You are not able to go out on a date and you start beating others who are going on Valentine's Day. ठीक है? Exact opposite behavior of what you want. What was sublimation? Unacceptable impulses converted to socially acceptable behavior. Like if you have a lot of violent impulses, you start doing what? You become a surgeon. And displacement is you are angry at your father, but you start beating your younger brother. So feelings are transferred from one to another. ठीक है ना? Pritika is saying projection versus displacement. Pritika, in projection, what you feel for others, you start saying that the other person feels the same for you. Whereas in displacement, what you feel for a person A is transferred to the person B, not to yourself. A 45-year-old man with severe depression and active suicidal ideation is considered for ECT. Which one is correct? We talked about it yesterday. Raised intracranial pressure was an absolute contraindication, but is no longer an absolute contraindication. There are no absolute contraindications to ECT. Even severe cardiac disease is not an absolute contraindication. Even pregnancy is not an absolute contraindication. There are no absolute contraindications for ECT. Sakshi saying minors, that's a rule, that's a law, right? That's a law that we have made. It's not a contraindication, it's a matter of law. Medically, so you can give it. And even with the law, there's a provision where you can take the approval from the review board and give ECT. We talked about it. Supported admission, which is done with the consent of nominated representative. This is a question from your old INICT exam, previous INICT exam. 30 days. 30 days. Self-admission, there is no duration given in the law. A 35-year-old woman experiences episodes where she feels detached from her body as if watching herself from outside. Reality testing remains intact. This is depersonalization. Feeling of unreality of self. Feeling of unreality of the world. Feeling of unreality of self and the feeling of unreality of the world. Depersonalization, derealization. Both of them usually occur together. A 30-year-old man with cocaine intoxication presents with, of course, sympathetic symptoms, hyperthermia, tachycardia, hypertension. What is the mechanism of action of cocaine? It blocks the reuptake of norepinephrine and dopamine. We talked about this. Because the norepinephrine reuptake is being blocked, that is why he is having all these sympathetic symptoms. And because dopamine reuptake gets blocked, what can it lead to? What can it lead to? Or what does it lead to? Bolo? Hyperdopaminergic state causes what? We talked about it yesterday. Hallucinations, illusions. We talked about it, na? The patient can present with hallucinations and paranoid delusions. Which neurotransmitter system is implicated in OCD? Serotonin. And which pathway in OCD? What is the name of the pathway? Cortico, striato, thalamo, cortical tract. CSTC. Very good. A 25-year-old patient with bipolar disorder is stable on lithium. Lithium level is only 0.7 milliequivalent per liter. What is this level appropriate for? So remember 1 to 1.2 milliequivalent per liter was for acute mania. Whereas 0.4 to 0.8 was for maintenance treatment. But we also studied that in the older books, 0.6 to 1.5 milliequivalent per liter is given as the effective lithium levels. So here it goes in the favor of maintenance treatment. Toxicity can happen beyond 1.5 milliequivalent per liter. ठीक है? इनसे 0.2 हो गया तो सब थेरेपेटिक हो जाएगा. Which of the following is the most common side effect? Sedation. But in the exam, they will usually talk about the side effect of Cialorrhea. For clozapine, exam question usually comes on Cialorrhea. Siddhant is saying, why not A? Because it's not the most common side effect. It's the most dangerous side effect. It's the most dangerous side effect, one of the most dangerous or lethal side effect. But it is not the most common side effect. Cialorrhea is quite common, but not as common as sedation. A 40-year-old woman presents with recurrent episodes of consuming large amount of food within 2 hours. So she's having binge eating, but no compensatory behavior. So if you only have episodes of binge eating, no compensation, it's called as binge eating disorder, which by the way is the most common eating disorder. Which brain region is most consistently implicated in PTSD? We know of two: hippocampus, in which memories are stored, and amygdala, in which the emotions, associated emotions are stored. So यहाँ पे hippocampus mark कर दो. Battery is low. A 35-year-old man believes his wife is having an affair despite having no evidence. He follows her and checks her belonging. And see, this line is very important. Whenever they want to give you a question on delusional disorder, na, they will give you history of a delusion, and they will say that functioning is otherwise normal. Functioning in other domains is normal. That makes it delusional disorder, jealousy type. Right? Why is it not paranoid personality disorder? If a person has paranoid personality, he would be suspicious not only on wife, but on everyone. Right? If you have a particular personality, it would be the same for everyone. So this is not a personality disorder. There's no reason for us to believe it's OCD or depression. Pranay is saying what functioning means. Pranay say, see this man say he's in a job. So when he goes to office, he works perfectly fine. He is good at his work also. So professional domain, his functioning is fine. Personal domain, he keeps on having fights with wife. The personal life is dysfunctional, but professional life is fine. Ritika is saying, why not C? Ritika, because in obsessive compulsive disorder, this is not seen. In obsessive compulsive disorder, a thought comes into the mind again and again, and patient himself knows that that thought is not true. खुशी कह रही है Cialorrhea का क्या पॉइंट था सर? खुशी बेटा तू 5 मिनट पास में चल रही है क्या? चलो खुशी का बर्थडे है तो खुशी को बता देते हैं. खुशी बेटा Cialorrhea का पॉइंट ये था कि एग्जाम में आता है. इट कम्स इन द एग्जाम. दैट्स द होल पॉइंट ऑफ ऑल दीज थिंग्स कि एग्जाम में सही होना चाहिए. चलो, which of the following sleep disorder occurs during NREM stage 3 and 4? So nightmares are seen in REM. Remember we talked yesterday, I had a nightmare. So nightmares are something that you can remember, and you can remember only things that happen in REM sleep. REM behavior disorder क्या होता है? Acting out on dreams as muscle tone is not lost. So see, this happens, no? So basically in REM sleep, the muscle tone is lost. Only your eyeballs move. Rest of the body's muscle tone is lost. And in REM sleep, you also dream. This loss of muscle tone is very important, because if you are dreaming and your muscle tone is still there, you might act on the dream. तुम लोग अपने सपने में उल्टी पुल्टी हरकतें करते हो ना? You do all kind of crazy stuff in your dreams. You are jumping from the roof and swimming and all that, what you do. If your muscle tone is there, you would start running on the bed or hitting others. So that is why nature has created this provision that there is no muscle tone when we are dreaming. Now in some patients, in some disorders like Parkinson's especially, the muscle tone is not lost. So what happens is, in the dream, whatever patient is seeing, he enacts it. So they sometimes end up punching the child who is sleeping with them or the wife who is sleeping with them. So this is called as REM behavior disorder. Okay. Sleepwalking happens in NREM 3 and 4. And sleep paralysis is again a phenomenon of REM sleep. Night terror is also seen in NREM 3 and 4 beta. A 28-year-old man reports recurrent panic attacks triggered specifically by public speaking. Now, remember the definition of panic disorder? Recurrent and unexpected panic attacks. But here the panic attacks are expected, triggered specifically by one thing, which is public speaking. So patient basically has fear of public speaking, which will go towards social anxiety disorder and not panic disorder. पूजा हुआ इसमें, right? नहीं हुआ? चलो. So the panic attacks are being, if they are being triggered in a specific situation, we do not make the diagnosis of panic disorder. Why is it not specific phobia? Because specific phobia is a larger term, larger diagnosis. If we are being given the option of specifically specific phobia, specifically social phobia, we will choose it as it is more specific answer for our question. The patient is having specifically anxiety attacks in a social situation, so it becomes social phobia, becomes a better answer. Yes, it is a specific phobia, but we have been given the name of the specific phobia, so we'll choose it. The best answer becomes specific phobia, so social phobia. Which medication is considered first line for treating alcohol withdrawal seizure? Again, we talked about this. Irrespective of what the withdrawal symptom is, whether it is only tremor, seizure, alcoholic hallucinations, delirium tremens, our answer would be benzodiazepine. Benzodiazepine. A 45-year-old patient with chronic schizophrenia shows minimal response to multiple antipsychotic trial. Of course, we are being given history of treatment-resistant schizophrenia. Here they have given a generic history, not specified the number of antipsychotics used in the duration. But for our purposes, let's recapitulate what was the definition. Lack of response to two antipsychotics, preferably one is an atypical antipsychotic, given for adequate duration. And dosage. So you start the clozapine. Depot formulation is used when we have been given history of poor compliance, that the patient is not taking the medications regularly. When there is history of poor compliance, then you use depot preparation. ठीक है बेटा? Which of the following is true about the dexamethasone suppression test in depression? So we know that dexamethasone suppression test shows us the HPA axis overactivity, which is present in only 50% of the cases, neither sensitive nor specific. Is it diagnostic for depression? No, seen only in 50% of cases. Is it specific? Normal rules of depression? No. The abnormal result indicates overactivity, that is correct. Routinely used in clinical practice? No. Something which is neither sensitive nor specific, why will you use it? A 30-year-old woman with no medical comorbidities experiences her first manic episode during first trimester of pregnancy. What is the safest treatment option? We talked about this in around, I think, 30 questions back also. Valproate is the worst, and the antipsychotics are the best. ठीक है बेटा? Which cognitive distortion involves focusing on single negative details while ignoring positive? This is called as mental filtering. So you filter all the positive things away and you focus on a negative thing. For example, say you cook a meal with 3 dishes and 2 types of bread and 3 types of desserts, and someone says that in one dessert it was too sweet, and now you say that I messed up the dinner. So you are focusing on one negative thing and ignoring the rest of the positive things. You are filtering only for negative things. You are ruling out all the positive things. This is called as mental filtering. What is all or none thinking? We talked about it in the class, that you think that if I get under rank 100, I am a successful student, otherwise I am a failure, or either all or none. What is overgeneralization? Overgeneralization is, say you made a silly mistake in the exam and now you say my preparation is really bad. So basically on the basis of one event you make a generalization. And quite similar is catastrophization. On basis of something you just catastrophize it, you say it's a disaster. So for example, made a silly mistake and saying my preparation is bad is overgeneralization. And if you made a silly mistake and now you say you are the dumbest human ever born, now you are not only generalizing, you are taking it to the next level. You are saying you are the most dumb person ever born. So that is called as catastrophization. Okay? So overgeneralization, taking small thing, making it general and making it huge, catastrophic, that is catastrophizing. Okay? Reasons for cognitive distortion, usually your early life experiences, and how do you treat it? By going into therapy. A 25-year-old woman with borderline personality disorder engages in self-cutting when distressed. Why she is doing it? So this is for emotional regulation. Physical pain relieves emotional pain. It can act as an attention-seeking behavior also. But if you talk to the patients with borderline personality, they would say that I was feeling so bad, was feeling so empty, so painful that physical pain was kind of relief from this emotional pain. So while some amount of attention seeking is also involved, primarily it is done for regulation of emotions. Yeah, this is like parasuicide. And when you talk to these patients, they say that they were not planning to kill themselves. This cutting was not an attempt to kill themselves. We have covered this question. Which brain circuit is most implicated in OCD pathology? It is CSTC circuit. These are some of the networks involved in the anxiety disorder. And mesolimbic pathway, we talked about it. Hyperdopaminergic state. In mesolimbic tract causes psychotic symptoms. Which of the following is true about informed consent in psychiatry? Patient with mental illnesses cannot give informed consent. Incorrect. You can't presume that. You can't presume that they cannot give informed consent. Capacity assessment is situation specific. This is correct. Psychotic patient always lacks capacity? No. Family consent overrides patient autonomy? No. So basically, what is capacity assessment? Say somebody develops schizophrenia. A patient has developed schizophrenia and now you are giving him the treatment options. Say you tell him that you should get admitted. Now, if the patient understands the need for admission and if the patient understands the consequences of admission and what may happen if he is not admitted, if he can understand these things, then we will say that his capacity is intact. Capacity to take decisions is intact. Just because he has schizophrenia, we cannot say that he has lost the capacity to take decision. Mental illness does not mean the capacity to take decisions has been lost. Okay? A patient with schizophrenia may also have the capacity. But if a patient has schizophrenia, you tell him the options and you find out that he does not understand the options or the consequences of his decision, then you say that he has lost the capacity. So it is a situation specific thing. It is not general. You cannot say that a patient with schizophrenia has no capacity. समझ गए? So they can give informed consent. This is the B. Did you understand the point? In simple words, just because someone has a psychiatric illness, do not presume that they cannot give consent. They can or they cannot. You'll have to evaluate it in that particular situation. A 35-year-old patient with panic disorder asks about long-term prognosis, which is accurate. Symptoms always resolve completely with treatment. That's not correct. There is no diagnosis for which we can say that 100% symptom resolution will happen. But most patients do have a good prognosis. We have got good medications nowadays. SSRIs work like a charm. CBT is also very effective. The condition will always worsen? No. Treatment is rarely effective? No. Which statement about Mental Health Care Act 2017 is correct? It allows unmodified ECT in emergency? No. Unmodified or direct ECTs have been banned. They have been banned. It criminalizes adultery? No. Otherwise, all the ortho SRs will go into jail. Just a joke. Just a joke. Just a joke. It mandates advance directive for all patients. No. I mean, you can give an advance directive. You can give an advance directive. It's not mandatory. But it decriminalizes suicide attempts? Correct. It decriminalizes suicide attempt? Correct. A 22-year-old woman with anorexia nervosa has a BMI of 14 kilogram per meter square and reports feeling cold constantly. Probably has hypothermia. On examination, she has a fine downy hair on arms and face. What are they called as? Lenugo. We talked about this now. In anorexia nervosa, because of changes in the hormonal profile, which is caused by starvation, there can be symptoms like amenorrhea and lenugo. Which antidepressant mechanism is associated with weight loss rather than weight gain? So we know that there is bupropion, which is usually associated with weight loss. And what is the mechanism of bupropion? NDRI, norepinephrine dopamine reuptake inhibition. Norepinephrine dopamine reuptake inhibition. ठीक है? बाकी SSRIs, SNRIs, MAO can all cause weight gain. A 40-year-old woman with recurrent major depression has a strong family history of bipolar disorder. During antidepressant treatment, which symptom would be most concerning? So basically, if a patient has a family history of bipolar and has presented with depression, we are concerned about manic switch. That patient has depression and we give antidepressant, we do not want her to switch into mania. And given that she has a strong family history, probably she has bipolar, but the manic episodes have yet not manifested themselves. So if there is anything which is suggestive of patient switching from depression to mania, you have to be very careful about it. So if the patient develops decreased need for sleep with elevated mood, it means probably she is going towards hypomania or mania. So you have to be very careful that if there is any such symptom, you have to immediately come to me and I will stop the antidepressants. समझ गए? Did you understand the question? What point is the question trying to ask? Harshit Gupta is saying, sir, what time break? Harshit, we have 7 questions left. Up to will complete it, beta. Pragati and Karthik are saying, please explain again. So, Karthik and Pragati, in some patients, when you give in some patients who have depression, when you give antidepressants, this can switch into mania. This is called as manic switch. And it is more likely to happen if a patient has bipolar disorder and you have missed the history. If a patient has bipolar disorder, he would have episodes of both mania and depression. But say today he comes to you in depression and you forget to take the past history of manic episode and you make a diagnosis of depression only rather than making a diagnosis of bipolar depression. In that case, what will happen? You made a diagnosis of depression rather than bipolar depression. You started the patient on antidepressant and he switched to mania. Now, the question is saying that patient is having episodes of depression only, but he has a strong family history of bipolar disorder, which means that the patient can later on have episodes of mania because of the family history. So if you're treating this patient with antidepressant, you have to be very careful that he is not switching from depression to mania. That is why any symptom which is suggestive of hypomania or mania, you should catch it immediately and you should immediately stop the antidepressant. Abhi samjhe? Did you understand it? Palak is saying, sir, are all atypicals NDRI? No, Palak. Nahin. Which of the following best describes the difference between ego-syntonic and ego-dystonic? So ego-syntonic is agreeable to self or acceptable to self. Ego-dystonic is not acceptable to self. So ego are more severe? No. Ego are consistent with same image? Correct. Ego-dystonic are psychotic? No. B. So ego-syntonic is seen in personality disorders. Ego-dystonic is seen in OCD. 55-year-old man with alcohol use disorder develops memory problems and make up stories to fill memory gaps. What is it called? Confabulation. What was pseudologia fantastica? Seen in factitious disorders. That is the stories that they make. So pseudologia fantastica is fake storytelling. Here it is actually because of memory gaps, confabulation. 67 क्या समझ नहीं आया? Ego-syntonic means agreeable to self, which is seen in personality disorder. People who have personality disorder, they like it the way they are. If somebody has, say, schizoid personality disorder and he does not talk to others, he does not show too many emotion, he likes it that way. He likes the way he is. Ego-dystonic is seen in OCD, does not like the symptom. When the patient gets repeated thought, he does not like it. When he has to wash hands, he does not like it. So, accepting the symptom, not accepting the symptom and accepting the symptom. Syntonic, accept the symptom. Dystonic, do not accept the symptom. OCD is not a psychotic illness. Khushi, it has got nothing to do with severity. Ego-syntonic and ego-dystonic are not to be confused with severity. A 30-year-old patient with GAD asks about non-pharmacological treatment. Which has the strongest evidence? We've talked about it. It would be CBT only. For most of the disorders, CBT is the therapy of choice. In phobias, we usually prefer BT, behavioral therapy. CBT is the therapy of choice. Which statement about rapid cycling bipolar disorder is correct? 4 or more episodes of depression, mania, mixed, hypomania, in 1 year is rapid cycling bipolar disorder. And which is the mood stabilizer of choice? Valproate is better than lithium for rapid cycling bipolar disorder. Cyclothymia versus rapid cycling, somebody is asking. See, cyclothymia में देखो ऐसे होगा. Cyclothymia में always there are some symptoms for more than 2 years. Rapid cycling bipolar disorder, manic episode, depressive episode, another depressive episode, hypomania. This is happening in 1 year. In cyclothymia, symptoms persist. There is no resolution. A 35-year-old man with schizophrenia has been stable on medications but wants to stop due to side effect. What is the most appropriate approach? Immediately stop the medication? No. Tell him about the risks and benefits. Ask him what is the problem. Can we change the medication if you're having a side effect? If you're having a particular side effect, we can change the medication. Of course, you don't refuse the request straight away. And the patient's autonomy is important. So this is the correct approach, not only for schizophrenia, but for all the disorders. Okay? Which change is most associated with antidepressant effect of ECT? This is a very old AIMS question before INICT. So how does ECT help in bringing down the symptoms? There are multiple hypotheses. One of the latest hypotheses is it increases the levels of brain-derived neurotrophic factors. So just memorize it. Just memorize it. Brain-derived neurotrophic factor. Just memorize it. Yes, Rachna, very good. This can help in the neurogenesis. A 45-year-old patient with anxiety asks about the difference between alprazolam and buspirone. So we know that alprazolam is a benzodiazepine. Buspirone, on the other hand, is a serotonergic agent. It acts on serotonin receptors. So benzodiazepines, more potent, immediate response, but dependence potential. This one, not immediate response, but no dependence potential. So both have equal addiction potential? No. Alprazolam has more addiction potential. Buspirone works immediately like alprazolam? No. It takes time. Alprazolam works immediately. Buspirone will take probably 2 weeks. Alprazolam has faster onset but higher dependence risk. The mechanism of action is also not same. Benzos work on GABA. Which of the following is true about catatonia? It occurs only in schizophrenia? No. In fact, catatonia is more commonly seen in bipolar disorder or depression than schizophrenia. ECT is the first line treatment? Yes, along with IV lorazepam. It always involves complete immobility? No. A patient may not have stupor. Antipsychotics are first line treatment? No. It's ECT and IV lorazepam. And now we come to the last question. A 25-year-old woman with bulimia nervosa asks about the most effective psychological treatment. We know that for most of these conditions, CBT is the therapy of choice. But if somebody is asking about specific phobias, we prefer behavioral therapy. For almost everything else, it's cognitive behavioral therapy. What is the difference between CBT and BT? As you can see, the difference is of cognitive. In behavioral therapy, you only work on behavior. In cognitive behavioral therapy, you work on cognitions or thoughts as well as the behavior. Okay? Dr. Dogra is saying, sir, I got only 35 correct. So in that case, beta, concepts are not good. Please go through the class once again. Please go through the class once again. If you are getting anything less than 60 correct, the concepts needs to be improved. Please go through the notes again, or you can watch the video again. And please ensure that you are adding everything to the quick revision notes or the mission workbook, and you start underlining during the revisions. ठीक है? Shivam is saying, sir, how reliable is GT AIR predictor? वो आने लग गया है? Is it showing now? See, we wrote the algorithm of that GT rank के basis पे all India prediction, and we used the scores from the last years. This year the scores were pretty much the same. So if we presume that the exam is of the same difficulty, it should be okay. But see, it's just a prediction. The real result may vary. It just gives you some kind of, either motivates you or it gives you a reality check to work harder. ठीक है? चलो guys. So I think from 5 o'clock GRG sir's lecture is there, END is there, and I think from 7:30 Zainab ma'am's is there. So some of you might be attending those also. ठीक है? And if you are following the Mission 3.0 schedule for next year, this should be the lecture. ठीक है? If you are planning for INICT, then Pharma and Zainab ma'am's are also important. So we will continue to stay connected in the Telegram group, and we'll keep talking to you guys. We still have a long way to go. Let's keep pushing, and let's remember that there would be ups and downs, but we'll find a way, right? Let's have that stupid faith that things will fall into place. All the best. May God bless you all. Keep studying hard.